So Angela Mitchell, I'm with Intel. I'm the manager for our U.S. healthcare delivery system. My role was brand new when they hired me about 4 years ago because they wanted to do something innovative and disruptive in healthcare, so they stole me away from healthcare to really start to partner directly with healthcare systems. So I'm going to talk to you about what Intel's done to be innovative in the healthcare space from a large employer perspective. And I've been doing this again for 4 years, and I have over 10 years of experience in healthcare coming into this job. I have my executive master's in public administration focused on healthcare reform. So I really wanted to get into the policy side, which I might still do in my career, but this has been a very rewarding job. And it's been wonderful as a large employer to really make an influence in innovating healthcare. John, why don't you introduce yourself?
Can I stand?
I guess.
All right. I'm John Jackson. I'm the Executive Director for Corporate Healthcare at Stanford, and what that means is basically I'm Stanford's ears to listen to employers and listen to what they want and how they want us to interact with them, and then put together relationships for direct care in a variety of ways. And so that's how Angela and I got together. My background, very twisted. I'm going to follow on Hal, though. So I actually have a degree in biomedical engineering. I have a master's degree in aquaculture. I used to be a fish farmer. So I went from fish farming to healthcare. I think of everything in terms of a pond and ecosystems and how things work together. So that's kind of what we've been trying to put together, is that ecosystem. That
amazing pond of healthcare, right? So here's Intel. I'm not going to get into the super details about who we are as a company. I think you should all know who we are. But yes, largest semiconductor manufacturer in the world. We have over 100,000 employees worldwide and 50,000 in the U.S. California is one of those big hubs. It's our corporate headquarters. Santa Clara, Folsom Markets, Oregon. We have the largest site. If you have ever been to Hillsboro, Oregon, pretty much the entire town is Intel. That's where I work. And then we have Arizona, where we're in Chandler, and Ocotillo, and then New Mexico. We have a fab there. And I'm super excited to say that we've launched connected care in all of those states now. So I'm going to, again, talk to you about that model. The thing to think about right now in this whole slide is how much money we spend on healthcare. So you see that second bullet in the middle, it's $690 million in the U.S., just the U.S. in 2016. So as you can imagine, lots of opportunity to start diving into where do we spend those dollars, how can we make sure that we're holding accountability for those dollars and making sure that their quality is coming out of what we're spending from a healthcare perspective. And Intel's done a lot of things in the last, I would say probably 20 years in thinking differently about healthcare, but I'm going to focus entirely on this solution that we've come up with in the last few years. So what is connected care? So it's our solution to disrupt healthcare for the right reasons. How do we disrupt healthcare? Well, instead of going through an insurance company and signing the checks year over year, we decided, why not go directly to the healthcare systems? So knowing that most people go local to see their providers, as was mentioned earlier in a presentation, even 3 miles is a long time for people to travel sometimes. We decided to go and do an RFI, just saying, what are you doing in the healthcare space? Are you innovative? Do you want to partner with us? Do you adhere to a patient-centered medical home? Do you believe in really engaging patients from a primary care perspective? Do you have an integrated system? Do you have a medical neighborhood? Do you believe in patient-centered care? Are you willing to think differently and be innovative with technology, knowing that our population is very tech-savvy and really relies on their smartphones, really, for most of what they do all day long, just like a lot of us in the room right now. So we chose the healthcare system partner. Stanford is one of 6. To partner directly with and start to put them in a pay-for-performance contract. And I'll get into a little bit of details into that, but that can get complicated fast. We measure on performance, so a lot of the standards are similar to, again, what government is already having healthcare systems report out. But we have our own data warehouser, and we benchmark on our population that signs up for these plans. So let's say you start off with your population of diabetes, and we know that there's 185 that have been diagnosed in your population. We're going to hold you accountable to bring them in control over time, I see nodding heads, for our population specifically, not for your commercial base, for Intel. We also look at different quality metrics on member experience, so satisfaction with experience. That's the surveys. What are they called? Now that I'm out of the business, I'm forgetting. It's Press Ganey that.
The CAP survey?
The CAPS, yes. So we do the CAP surveys that are primary care, and we look at, after you've seen your primary care doctor, did you enjoy the experience overall, and how was the quality of care from your provider? And then we also look at areas for access to care and alternative venues of care. We know that telehealth can be hard to start, a population, especially in a high deductible, to figure out that this is a cheaper and better solution. Potentially, you won't have to go in to see a doctor physically for a lot of services, so we require that all of our healthcare system partners either implements that and integrates it into their healthcare system, so not an insurance third party that doesn't have any clue who you are as a patient or your history, but the actual healthcare system. Those providers are doing the telehealth. So we have that with all of our partners. Stanford's launching pretty soon. You already have it. It's hard to keep track of 6. But it's something that we know is important. And we've seen a big uptick because we promote it on the campus. So we talk about telehealth. We talk about video visits. We talk about calling your doctor, emailing your doctor, because we really know that it's obviously it's cheaper, but you don't always have to physically go in. Also for moms and dads that are at home with kiddos, to not have to load all your kids in the car and go in when you know it's strep throat because your kid gets it every year, it can be quite the convenient experience. So alternative venues of visits, access to care, getting quicker into your doctor's office. We measure on that. And again, all of these metrics aren't things that we went off and decided to design ourselves. We don't need more data in healthcare to measure doctors on and performance on. So we partnered together with all 6 healthcare systems. They're not all identical, but they all have the same triple aim dynamic going on. There's always going to be cost, quality, and member experience. And then obviously pay for performance. I'll get into the model of that in a minute. And then a member-centric or patient-centric design. So we asked our employees what could be better in healthcare, and we listened. And then we worked with the healthcare system partners. And my job was to really make sure that they listened, and that they started to change the way that our employees were saying healthcare could be improved, which they've all done. So here is, at a high level, I'll get into essentially what we do is we sit down with our partners and we look at the different metrics. And in that scorecard of metrics, cost is a component. This is the cost part. So it's a value-based payment model where we're, out of all the costs that we spend as a company, through this plan, Connected Care, which, by the way, all of them are high deductible health plans, and we have over 80% of our entire US in a high deductible. And we also give them HSA seed money to join, $500 for individual, $1,000 for families. So there is an investment up front employers need to make, but it pays off, and I can show you how. And then each contract over a 5-year period of time has a certain percentage of claims at risk, right? We're asking for them to bring their costs down over time by better management of our population. So that's what we sign up for together. And then we work together monthly on data, and I come to the table with them, and we have good discussions on what are we doing in the engagement process. Are we thinking differently about not just cold calling with a team of people, but how about we have an actual dedicated nurse that's going to be in charge of calling folks that we already know are diagnosed with diabetes or hypertension or both? And how about that personal touch is continued throughout the process of care? It's just an example. We work with each other on a lot of different aspects of the model itself. Again, having someone from the healthcare industry, I was doing that work in healthcare, and now I can do it for Intel. So that's the payment model. I'm not going to get it. It gets very complicated very fast. So again, not going to go into details. But we also partner with the healthcare system actuarial team to make sure that everybody is aligned by the time that we go live. This is a slide that I'm going to come back to. I meant to put that at the end. So here are the different healthcare systems that we partner with. So again, knowing that healthcare is local, it didn't mean that we just went out and said, okay, Kaiser, you're in Oregon and you're next to Intel's campus, we're going to choose you. We really did pay special attention to make sure that they were adhering to the various parts of our model that we needed them to. We also require healthcare systems to think differently about plan design. So we don't have any referrals required. in connected care, and we don't have any prior authorizations. That's a huge change for healthcare, especially when you're held accountable, right, for a population. But we don't care. We want it to be easier to access care, and we want to put medical management away from the insurance side of the business to the doctor side of the business, because they went to school for this, right? We spend a lot of dollars on medical management, and I'm not too sure how you guys feel when you get a phone call from someone that doesn't really know anything other than a claim that came through 6 months later that you need to go get your A1C done. It's much more impactful coming from a healthcare system provider. We all agree, right? Okay, so these healthcare systems, I will tell you, were one of several in each state, and they all were willing to think differently. They all were willing to put resources on the table to launch something in a much quicker time than what makes any kind of sense in healthcare world. I mean, we're talking months to get from the onset to live for all of these states, and I led all of these, and I'll tell you, this is the first year I haven't launched one, and it's been nice. It's been busy, but it's been manageably busy. So yeah, 38,000 members are in these plans, which is awesome. We want to keep growing. We want to keep seeing more families join, and over 90% retention, which means obviously they're enjoying their experience because they could leave if they wanted to. The uniqueness of California. So when we went to California, we knew that we had Santa Clara and we had Folsom. And we knew that people don't drive the 100 miles, right? No one wants to do that in California anyway. So we decided to have they decided to partner together to have one network. So if you're a member of California Connected Care and you're in Dignity, the Folsom area, you could go to Stanford and network to their network here, should you choose to, and then vice versa. So that's the uniqueness of Stanford and Dignity. It's very innovative that they decided to do a partnership together. I wanted to make sure to highlight that.
Yeah, I think partnership is a stronger word than we should use, so it's a cooperation.
Right, sorry.
Partnership implies that there's some sort of joint ownership or shared risk between us and Dignity. There's not. We're cooperating. We're cooperating to make sure that we meet the experience of the members in connected care, i.e., we don't want someone to be left in the lurch if they happen to cross over the borders between Stanford and Dignity. You know I'm sensitive about that.
I know, sorry. Forgot about that one. Maybe I don't care either. I don't know. All right. So here are part of the model requirements. So what did I do when I first met you, John? I showed a presentation on here's all the care delivery requirements that we want. Again, coming from healthcare, patient-centered approach, medical home approach, concierge approach, an actual human that's going to help you, a dedicated care team to manage the chronic population and the pre-chronic, the ones that are kind of on the way. Alternative venues of care, I've gone over all this with you guys already. Thinking innovatively about technology and tools in an integrated fashion, not, oh, we have a vendor and a vendor and a vendor. No, we want to integrate it so it's a seamless experience. Reducing costs and improving value, there's different ways we do that. Interoperability, as you can see, is really the foundation of a triple aim. If you don't have data that's moving in a network, in an integrated system, then you're not going to have a triple aim. So. This is in a nutshell what it is. Obviously, you guys, a lot of you, who's from the healthcare industry? Raise hand. And then who's employer? Or who's both? Oh, okay. You can start this with your employees. So I think as you guys know in healthcare, none of this is rocket science. You have your patient-centered medical home models. You have the ways that you need to deliver care, especially for those that are the most vulnerable. And you know your populations, right? So that's an important piece and something that John's done a great job at Stanford in really understanding Intel and the technology and tech savviness that comes with us, making sure that they're in the forefront of communications and showing how easy it is to access care versus expecting them to figure it out because they won't. So that's really an important piece to all of this, is to cater it and expect the healthcare systems to really customize it for your population. Interoperability has been one of the most popular pieces of connected care and has been recognized by the government. ONC specifically loves it because we are doing something in interoperability that's actually working and we have data to prove it. So here you can see direct messaging, e-health exchange are the way that we partner with the systems to start to think differently about throwing their hands up and saying, well, they're on X, Y, and Z EHR, and we're on Epic EHR. That comment earlier was amazing, Rusty, wherever you are. And we're not going to, we can't really do much about that. That's just how healthcare is. Well, no, you can do something, and you probably already have the tools to do it. You just aren't doing it. So we incentivized just simply by being at the table, not financially, to be able to really start to get these systems to start using the technology, and it's working now. The way that we were able to really leverage from the beginning in Oregon was because we have on-site clinics. So as I was mentioning earlier, they were on Greenway. Our healthcare system partners were both on different versions of Epic. So that's the focus. It was on get data to connect and care delivery to connect on site at these clinics. And then from there, we've grown it to be the entire network. Because as even with Providence in Oregon, they have different provider groups that aren't Providence doctors that they've added for different types of specialty. And we're doing direct messaging referrals through their system to securely exchange data so that those doctors have the history information, the medical information that they need to make the best decisions for our patients, our members. I still say patients. So how is it working? This is the slide that I love to show. This should be the only slide I show. So it's working, and we're doing good. We're up to 31% in the U.S. enrollment. There's other options on the table. We don't force people in. We incentivize them to join for the first year, and then they can leave, and they don't for the most part. Member satisfaction above 91%. That's across the board for all of our programs. What's important, I think, to employers, obviously, is cost. So you can see here, compared to our national plans, the red is national, and that's our spend, and then the middle is our average. And then the green is our connected care population. So that's showing you that we're spending less, and the really awesome part is the higher risk the members go, the less costs we're spending. So we're expected to spend more as people get sicker, right? Every employer knows that. Well, in connected care, because it's this high integrated, high touch, high quality network, all of them are, we're seeing that their experience is more cost efficient because of that. That we could get into lots of conversations about how, but at a very simple way of looking at it and presenting it, this is a good example of us being able to show now that it's working. Another piece that's awesome. So depression management. As a company, we know that our employees are in a position where this is an area where they could use some extra help. And we require depression screenings, PHQ-9 screenings, to happen in primary care. So when they go in to see their primary care provider, they're getting screened, and we're managing that. And as a result, we're seeing this trend now where connected care members are receiving more diagnosis in the actual patient-centered medical home setting instead of in higher costing settings. And they're getting a lot of preventive help, and they're getting less medication prescribed to them as a result. So more of that preventive focus, so go seeing a counselor, different settings that could hopefully get them in a better position and treat them at that time versus waiting until it's gotten pretty bad. So overall, lessons learned, it's definitely a journey. It takes a team. It wasn't just me. It takes a team of people that are really and leadership at your company and your HR. Tammy Graham is the leader at Intel that really fought for this to come to fruition, and has been a tremendous leader, someone who I highly respect. It also takes a team of people in your contracting department, analytics department, finance department, coming together, and then it takes healthcare systems who are also committed to bring the same experts to the table. And it's disruption for the right reasons. The best part of connected care, in my experience and journey at Intel, has been the light bulb moment where healthcare systems start to really leverage the employer relationship with Intel, bring us to the table, have fun discussions about innovative ideas, and then start to really use us and the power of us as an employer with their own leadership teams. Then they all of a sudden start getting approval and funding to move the ball forward on a lot of really neat, innovative solutions that are proven with data, because we're obviously watching a lot of data coming out of these populations. It's kind of a no-brainer, right? If you're going to pilot something, why not pilot it with connected care, right? So that's a fun part of my job, is I get to work with them on all these different pilots, use technology, use different innovative ideas, and then watch the results in real time improve for the health of the population. And the healthcare systems love it, because coming from healthcare, it takes a long time to get things approved, usually, especially if it's causing leadership to think differently. And this is a great model, an employer model that really does work and gets folks to start thinking differently. And I can say things in meetings, and well, you know, I'm not working for the healthcare side anymore. And nothing's exact. So when you go into each market, as we all know, every healthcare system culture is different. Every population of intel in each state is different. So we really have to treat each one differently, but the core tenets of the model remain. The risk is always going to be there. There's always going to be accountability for care. There's always going to be a care delivery model with those same attributes. We have 3 minutes left. Shoot. John called me on this. He has slides in here. He's like, I'm not going to talk.
I win the bet, by the way.
Should we just open it up for questions?
Yeah, I was going to say, I don't think we were going to talk a little bit about kind of the provider side of this equation. I don't think we need to. I think there's only one relevant fact for any providers, which is this has to be a partnership, and it's difficult. It's not because Intel's difficult. It's difficult for hospital systems and providers to listen to what the payer, the employer wants, and respond to them in a business-like fashion. This is not what we do every single day as an organization. You know, every single day as an organization, we treat individuals, we treat patients, et cetera. We don't know how to have these conversations.
Now you do.
Now we do. And so if you're going to enter into these, you want to think about that partnership. So that gives us 2 minutes, which I think is 1.5 questions. There's one way in the back, if we can.
There's like
get
two back there.
There's a few back there.
We'll go to the back real quick.
We have to wait. We're told we have to wait, Lauren, for a microphone.
Yeah,
Sorry.
otherwise people on the webcast cannot hear you.
Hi, that was a great talk. And John, your closing statement was perfect. I just really want to say thank you for that. Angela, you referenced that you're doing these pilots and that the partnership allows you to experiment and do some pilots because you're working directly with the healthcare system. Can you just sort of illustrate for us one that has been particularly, that you're enthusiastic about, and also the degree to which you're using your multiple sites to have the sites learn from each other, Oregon, Arizona, New Mexico, California. To what degree are those sites all learning from each other based on success with some of these pilots?
Those are both really good questions. So some of the pilots are different approaches to engagement. So a lot of the dedicated care team management, a couple that I'm going to name, and I'm not going to name from who, because I haven't gotten approval to, but we do predictive modeling now with some of our healthcare partners. We do high-touch chronic management in home, so thinking about different ways where folks can track and monitor with in-home devices. We've done genomic. I'm probably not going to get into too many more details than that, but just think about all the different things on your guys' roadmap and what you would do if you were highly managing a population. You do this with your Medicaid population, right? This is for employers. So what can you do for employers? They are not technically all working together. That's something that is on my roadmap, is to bring all of them together this year, because we just finally launched California, and now all 6 of them coming in a room to share best practices, just like you'd think of a Medicaid CCO group, similar. So with not any time left, I will say that will probably happen sometime by the end of this year.
Yep.
Okay.
We're already over time, so
yeah.
I
Thanks,
know Angela
everybody.
and I are still around. Thank you.